Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Til Luca.
Welcome to the Thinking Practitioner. The Fascia Research Society invites listeners of the Thinking Practitioner Podcast to the 6th International Fascia Research Congress in Montreal, September 10th through 14th, 2022. 8 keynote speakers, including our special guest today, and over 60 parallel session talks and posters, 15 workshops, including one from Til on September 11th, and the full Congress schedule is now out. Register for the 6th International Fascia Research Congress today at fasciaresearchsociety.org. Hi, Til. How are you? And we have a special guest today. Who is it that's with us?
I'm great. Thanks, Whitney. I am really pleased to have Dr. Helene Langevin with us today. She is the director of the National Center for Complementary and Integrative Health, the NCCIH, the U.S. federal government's lead agency for scientific research on the diverse medical and healthcare systems, practices, and products that are not generally considered part of conventional medicine. Her own research interests, she's also a researcher, include the role of connective tissue in chronic musculoskeletal pain and the mechanisms of acupuncture, manual, and movement-based therapies. Her more recent work has focused on the effects of stretching on the resolution of inflammation, a topic of great interest to me, within connective tissue, and we'll ask her more about that in today's conversation. Dr. Langevin, thanks for joining us. I'm so pleased to have this bit of time with you, and I appreciate you taking that. Anything else you want people to know about you or what you're bringing to the conversation today?
I'm just very, very excited and honored to be on this show. Thank you.
Oh, thank you. The honor is ours. Anyway, the Boston Globe said you're a celebrity in the world of acupuncture and that your work has, and I know from my own experience that your work has made you a celebrity of sorts within the world of fascial therapies, which is my bailiwick. And your research has included topics that are pertinent and interesting to manual therapists. You ask some really interesting questions, apparently, and then you go find out about it or write about it in ways that help us all learn more of what's going on that level. For example, the role of some of your topics that are really interesting and relevant seem to be the role of tissue stiffness and pain, which has lots of implications. Is stiff tissue painful tissue, and how does that relate? The effects of stretching on cell function and an inflammation resolution. Can you actually change inflammatory processes or cell functioning through stretching? And your research has some really interesting observations. And you've also written on the science of interoception and proprioception and tissue qualities, really interesting topics. So I want to get into specifics about at least a couple of those. But first, before we do that, what would you say are the common threads here? What kind of big picture questions did you have, or background or perspectives did you have that prompted you to choose these lines of inquiry?
Well, I would say the biggest thread that runs through my entire career is really, I think connective tissue is kind of a metaphor for connections, things that connect, things that we typically sometimes think of as not connected. So that really intrigued me very early on. I actually stumbled upon connective tissue by accident. I was interested in acupuncture, and we found out pretty early in my lab, the first couple of years I was doing research, that actually when you insert an acupuncture needle and then you manipulate the needle, there's a very, very interesting mechanical relationship or reaction that occurs in the tissues in response to the manipulation of the needle. And then what we found out is that this is actually the connective tissue kind of responding and being sort of moved around, essentially like a little micromanipulator. And
you're showing us with your hand a kind of twisting motion.
Yeah.
For those people that don't know much about what acupuncturists do with needles, how would that go?
Acupuncturists don't simply insert needles. They actually manipulate them. They rotate, sometimes they push and pull, and they feel for something in responding in the tissue. That's what tells them what to do and when to stop manipulating when a certain response has occurred. And pretty early on, we figured out that it was essentially establishing a mechanical coupling between the needle and the tissue. And so there was a small force essentially being communicated to the tissue through the needle. And the connective tissue was responding to that. And that really made me think about, well, what is connective tissue? And I found out there was actually very little research on connective tissue at the time. This was back in the 1990s, late 90s. And if you looked at textbooks of orthopedics or rheumatology, where connective tissue should be, there's almost nothing there. So it was sort of a tissue that had fallen through the cracks. But meanwhile, there were a lot of
I like that.
But there was a lot of practitioners, manual therapists in particular, who cared a great deal about what they were talking about, connective tissue and fascia. People were starting to talk about that. And as though it was important clinically, but it was really very little research on it. So the combination of the two things, the fact that this was a tissue that's all over the body, that is very poorly understood, but may have very sort of some clinical importance. That was very intriguing to me right from the start. So that's really kind of a thread that's been through a lot of things that I've done.
It's fascinating, and I think I don't remember which one it was, but I remember hearing about your work, and then I believe hearing you speak at some of the previous fascial research congresses that were really eye-opening for me, and they were great for me as a clinician to see how scientists and researchers were thinking about these questions. And I want to ask about one study you did in particular where you used ultrasound to show that people with chronic low back pain had thoracolumbar fascia that was stiffer, say, than those without lower back pain. Can you tell us something about what we know or what you're learning about the relationship between tissue stiffness and pain?
We actually did not measure the stiffness of the tissue. This is important. We measured two things. We measured the thickness of thoracolumbar fascia, and then we measured what we call shear strain, which is the relative motion between one layer of fascia and the layer immediately next to it. And so we used ultrasound. It's a technique derived from ultrasound elastography, where you're actually measuring the movement of the tissue in response to a specific input motion. In this case, it was the human subject was lying on a table, on a motorized table, and the table was bending back and forth, and such that the thoracolumbar fascia was kind of put under stretch, and we wanted to see how
much, like
a
sliding between layers or something like that.
Exactly.
Yeah? Okay.
So difficult. Well, there are other techniques that can measure stiffness in tissue. One of them is what we call shear wave elastography, which is where you send an ultrasound pulse through the tissue, and then there's an ultrasound wave that propagates, and then the speed of propagation of the ultrasound wave correlates with the stiffness of the tissue. We didn't do that. We were interested in the shear plane motion, and the reason for that is because we know that fascia is organized in layers, and that these layers have independent motion. We were actually really surprised when we did this testing on the ultrasound, with the subject on the table with normal human subjects. We observed shear strain of an average of 75%. That's a lot of shear strain. So imagine you put your two hands on top of each other like that, and slide them completely all the way off. That's 100% shear. Well,
so sliding them apart from each other. 100% shear is completely
100%
apart.
shear is when the whole two little sort of pieces of tissue will, you can look at this for a specific segment of tissue, when the two segments would completely sort of separate.
Displace. Yeah.
But in a normal human subject, on average, it was 75% shear. And that's a lot. That really intrigued us. This is an important component or quality of the thoracolumbar fascia, is that all of these layers that are composing this fascia, they all are aponeuroses of different muscles that have different directions of pull. Some of these muscles have a rostrocaudal, right, from top to bottom direction of pull, and some of them have a lateral direction of pull, like the obliques, for example. It makes sense that these muscles these aponeuroses would not all be stuck together. So we were actually very happy to see that we were able to measure that. So then we looked at people who had back pain, and we found that on average, that shear strain was reduced to 50%. So that was a big difference.
Not as much sliding between the layers within the tissue.
Sliding, which means that the motion, the relative motion of these layers was less independent, which suggested that there was perhaps a sort of kind of like almost like an adhesion that was starting to take place. We were not able to know that this was taking place in humans, because you cannot go and take a biopsy of somebody's thoracolumbar fascia. But we tested that hypothesis in an animal experiment where we found that indeed the layers were more adherent.
Do you have any theoretical ideas or thoughts about whether that loss of that is a result of the pain that those individuals were experiencing, or if that was a cause?
It's a really good question, and we don't know. The only sort of slightly sort of indirect way that we were able to test that was in that animal experiment where I mentioned, where we reduced the amount of stretching that the animal was able to do, and in response to that, the layers became more essentially stuck together, which suggests that if somebody moves less for whatever reason, it could be because they have pain, or it could be simply because they don't move, they're sedentary, they don't stretch a lot or move a lot, then that will then result in a reduction in their thoracolumbar fascia shear strength or mobility. So it could be, we don't know, it could be a chicken or egg, right? And then once somebody's fascia becomes less mobile, then they move less, and then maybe that will kind of make their pain worse, but we don't know which comes first.
Yeah, fascinating.
What's the important question, Whitney, about is the stiffness preceding the pain or a result of the pain? And I really appreciate your answer.
Because there are these sort of, imagine that you have certain habits of posture, of movement, that then results in remodeling of your connective tissue, that then, kind of could also lead to pain on their own, right? Because entrapment of little nerve fibers in these glued up layers then can maybe lead to pain. We don't really know, but this is, whatever reason there may be pain in these tissues will then change the movement pattern of the person. People move differently when they have pain. So there could be these kind of reinforcing circles that we don't really know where they start. So.
And then there's the question of how do we change those cycles? What can we do that might influence that?
This is from happening, and so a lot of these therapies, they can act either locally or centrally. You can, for example, instruct people on how to become aware of their movement patterns through awareness, these movement therapies, where you help people to get out of these sort of stuck movement patterns that they have. They're always moving the same way. Or you can get your hands on the person, feel where they have areas where there's restriction, perhaps mobilize some of the tissues, some of the connective tissue that has become sort of stuck. Or you can help people who have contracted muscles, help them to relax those muscles in order to improve movement. So there's a lot of techniques that can be used, both manual techniques and also movement-based techniques. What we don't know is a lot of the mechanisms of how these techniques work. There's a lot of experience among clinicians as to how to apply those techniques, but very little research on this.
And then I know in some of your other writings, like you're writing about interoception or proprioception, there's a lot we don't know about how perception happens or how the experience of pain is generated from that too.
That's right. Most of what we know about pain comes from the skin, right, or nerve injury models. Very little understanding of the sensory innervation of deep tissues. When we're talking about musculoskeletal system, fascia, muscles, etc., we know that there are sensory nerves in these tissues, but we know very little about what type of sensations these sensory nerves transmit. How do you feel? My favorite example of this is that imagine you take your forearm and you grab your forearm and then you twist it and you hold it. what kind of sensations are you feeling? These sensations are definitely, you can feel stretching. Maybe if you twist hard enough, you may feel even a little pain, but you certainly feel something. And the sensation is coming from your deep tissues. And we don't know what sensory neurons are carrying on these sensations, So this is just an area that's almost a bit of a black box. And when we have back pain or neck pain or shoulder pain, or some of these sensations are probably arising from these tissues that we know, very little about. So this is one of the reasons why at NCCIH we're starting to really pay a lot of attention to the kinds of research methods that you need to better understand sources of musculoskeletal pain, including myofascial pain. So we recently had a workshop on this, and we developed some funding opportunities to encourage people to develop better methods to do imaging and different types of functional kind of testing of these tissues to better understand what's wrong. When people have myofascial pain, can you measure it? And also, if you treat it, does the pathology get better? And what are the objective measurements that you can make in order to see whether a particular treatment is ameliorating the actual condition of the muscle, in addition to the patient hopefully feeling better?
Well, a lot of us are on the edge of our seats as you go
That's
through
right.
these questions and find it's the little tidbits that come out, sometimes major tidbits. I was just looking at your 2021 paper, Fascial Mobility, Proprioception, and Myofascial Pain. And I want to recommend it to our listeners. We'll put a link to it in the show notes. And also just really appreciate and thank you, Dr. Langevin, for being so clear about what we know and what we don't know, and making room in that too for the possibilities of what those implications might be in wonderful ways, but not overextending ourselves into realms where we're starting to lose practicality or lose a sense of what we're up to in a way. I just really appreciated both the information you shared and the way you constructed your narrative through that. Thanks very much. Well, can I ask about inflammation? And by the way, before I do that, thank you for correcting my use of the word stiffness in terms of what you found in the thoracolumbar fascia, because you found shear strain, you found movement differences and thickness differences, but stiffness, as I understand it at least, is something that would happen over time, a change over time. A sense of, or viscoelastic changes, things like that could be stiffness.
Yeah. It's something that needs to be measured in a different way.
Measured a different way.
In fact, some of the techniques that we discussed at the workshop on myofascial pains would be able to measure stiffness.
Okay.
So, for example, the shear wave elastography that I mentioned is such a technique, and so we're very much hoping that some of the this is some of the research that will occur in the future might be able to address that.
Well, your various research findings, and then of course others, have really influenced the way I practice my manual therapy. I'm thinking much more in the last decade, say about sliding, about shearing, rather than just the stiffness instead of what's stiff in terms of what I'm working with. So like I said, we're waiting on the edge of our seats. And then when we get to something like inflammation, which is a process that's so pervasive or linked with so many of the complaints we see in our practices, you have a fascinating tidbit that your research has shown where stretching can actually influence inflammation in certain circumstances. Could you tell us something about that?
Well, what we know is only from some animal models,
Yeah.
but in those animal models, we did find that gentle stretching, and I repeat, gentle, can have an effect on inflammation, that it reduces inflammation in these animal models. And what we think is happening is that stretching is actually helping the animal to promote what we call the resolution of inflammation. It's not suppressing the inflammation, it's helping the inflammation to resolve. And there's an important difference between the two. If you take, for example, Advil or some other anti-inflammatory agent, it suppresses both the inflammation part, but also the resolution part. But if you have your sort of natural built-in inflammation resolution, which occurs in any scenario. Say if you cut yourself and you have initially for the first 3 or 4 days, the cut is red and sort of tender and painful, and eventually it kind of stops being painful and then the swelling resolves. That's inflammation resolution. It's part of the inflammatory response. From the very beginning of the inflammatory response, there's a program that starts itself in order to terminate it so that inflammation doesn't keep going on forever. And what we found is that stretching encourages that resolution.
Encourages that resolution, that cycle to continue through. And the gentle qualifier you gave is also really interesting, because for a long time there have been explanations of manual therapy's effects that we might provoke inflammation, or we might stimulate fibroblast activities to repair, that we're essentially damaging perhaps tissue in a way to reboot an inflammatory response. And you're giving us a whole different map. You're saying a gentle stretch seems to help resolve.
I can't comment on efforts to increase inflammation. All I can say is that whenever you do a manual or a therapy or stretching, or if you impart a mechanical force that's large enough to be injurious, that will increase inflammation. I mean, because you're creating an injury. What we notice is that regardless of if you do the kind of stretching that we do in the lab, or even when you do the acupuncture that I noticed that I talked about at the beginning, where you gently manipulate the needle, you don't see swelling, you don't see increasing neutrophils in the tissues the next day. You don't see evidence of increased inflammation. If anything, it's a reduction.
And I'm assuming too that that type of intervention, you wouldn't have a stretching procedure that would speed or have an inflammatory resolution occur prior to when the body kind of said essentially we still need to have something going on here. Like it's not going to speed it up so much to a point that it's decreasing the therapeutic benefits of the inflammation.
Right. So, but what it's doing is it's kind of working in concert with the body's natural efforts to resolve the inflammation. And the reason why we think we can say that is because we can measure specific compounds called pro-resolving mediators. They're derived from lipids, from omega-3 fatty acids, and our body starts with these lipids that we take in our diet, like from fish and stuff, and then it makes these compounds called pro-resolving mediators, or resolvins, for example, is one kind. And those are compounds that are several-fold more active than the omega-3 fatty acids themselves in resolving inflammation. Very, very active compounds. And so we think that the stretching and the movement sort of cooperates with that response. It kind of encourages it. And because we can measure the level of these pro-resolving mediators in the tissues in response to stretching, and they're increased.
So why does inflammation not resolve? What gets in the way of it actually doing that on its own?
It's a little mysterious. And so this is a lot of the work of Dr. Charlie Serhan, whom I was fortunate enough to collaborate at Brigham and Women's Hospital in my previous job. And what he talks about is the balance between the pro-resolving and the pro-inflammatory mediators. It's a complicated picture because it's very dynamic. There's not just one or, you have a lot of different inflammatory mediators that are contributing to the overall picture of whether the end result is going to be more inflammatory or more resolving. And in the end, depending on that balance, you get what you get. Either you get a non-resolving inflammation, which continues, or you get a resolving inflammation, which just kind of, it ends. The inflammation.
It winds itself up and it's done.
The heat, the
whatever. The acute phase starts to resolve, Right.
Otherwise, it turns into chronic inflammation.
Mm-hmm. It sticks around and keeps doing its good and bad things in a way that's not good.
And we know that the end result of chronic inflammation is deposition of collagen and fibrosis and adhesions. And this was very, very nicely demonstrated in an animal model. So wonderful studies done by Mary Barb and Jeff Bove at Temple University, where they did a repetitive motion model injury on rats. They trained them to pull a lever many, many, many times a day to get a reward and they kept increasing the force that it took to pull the lever. And these rats actually developed inflammation in their chronic inflammation in their forepaw. And what they then did is they did manual therapy on these rats, if you can believe it. They massaged the animals, and they found that the animals that had the daily manual therapy kept their function. They were still able to do the movement without getting the inflammation as nearly as much. So this is very interesting how you can see how these rats were getting chronic inflammation, and the manual therapy helped to they didn't measure the pro-resolving mediators in that experiment, but the amount of inflammation was certainly diminished.
That was a really interesting study when that came out. It's been a while since I've read it, but I think if I remember, they were actually observing the neurons or the cells within the nervous system to try to measure inflammatory response in some creative way.
They looked at the connective tissue surrounding the nerve because, and this is important again, normally, right, talking about shear plane motion, a nerve has a sheet of connective tissue around it. And this sheet of connective tissue should be mobile. The nerve should not be stuck and attached to the surrounding muscles. But when you have fibrosis, you can get fibrosis around the nerve, which then makes the nerve essentially less mobile. There's less shear strain between the nerve and the surrounding tissue. And what they found is that there was less fibrosis surrounding these nerves in these animals. And they measured this degraded myelin-basic protein in the nerves, and it was elevated in the non-massaged rat, and it was near normal in the massaged rat. So the nerve injury was prevented.
So we have that interesting evidence or interesting study in rats about massage or manual therapy ability to help resolve inflammation. What can we extrapolate from that or guess, or what do we know about our ability to influence resolution? That's like the huge question behind all this. But what do we know about our ability to influence that?
We don't know a whole lot other than there's a lot of effort in the pharmaceutical industry to develop compounds that you could take, like resolvent, to improve inflammation resolution. So far, I mean, for example, omega-3 fatty acids, a lot of people think that you could, by taking fish oil, that you could improve inflammatory conditions. The one condition where that has been shown is rheumatoid arthritis. Patients with rheumatoid arthritis who take a supplement of fish oil have been shown to have reduced inflammation. So, but not other conditions. People have tried with other like asthma and inflammatory bowel disease, and it's not like the cure all that people were hoping.
Yeah. So I want to kind of take off from what you were saying too. This is fascinating about these rat studies and the changes that they found from soft tissue manipulation. From your perspective and the work that you've done, what do you see to be some of the most significant effects of manual soft tissue manipulation on the fascial system? Like, what do you kind of sense to be the most impactful or powerful of those effects?
I would say that one of the important things is, I already alluded to, is that more is not necessarily better, right? That you have to be very careful about how much you do, whether it's movement, exercise, or manual therapy. The dose matters, and we need to understand better how to apply these forces without further injuring the tissues. And the other thing that's really important is to make sure that we understand the status of the underlying tissue. Imagine you have somebody who has either hypo or hypermobility, right? We've described a situation of hypomobility where layers are stuck together. But what if there's hypermobility? Patients who already have very loose connective tissue, like, for example, Ehlers-Danlos syndrome, or the sort of generalized hypermobility disorders, which are quite common. What do you do in a situation like that where somebody has pain and their tissues are already very mobile? You're not going to want to stretch them more, right?
Not going to be looking for more shear strain or more mobility necessarily.
Yeah.
You could damage the tissues by, and sometimes this happens. People who have hypermobility, and they'll go and they do yoga, and that they injure themselves because they're trying to stretch and they're already too much mobile.
Mm-hmm.
So the important is to be able to be judicious about when do you need to increase mobility via either stretching, or what you may need in a lot of cases is strengthening the muscles so that they can support the tissues more. Importantly, they may be a combination of the two. You may have somebody who's hypermobile generally, but who've had some injuries, because a lot of people who are hypermobile have had a lot of injuries. And then in some cases, locally, you may have some areas of hypomobility. So you may have a mixture. People may need to be mobilized in some areas if they're stuck or they have a scar or an injury or an adhesion, but not everywhere. So this is where the art of the therapist, comes in, and be able to really, understand that by palpating and feeling the tissues and watching how the patient moves.
Well, you've spoken eloquently in a couple of different places about contextual effects or non-specific effects of our work too. So when we think about someone with hypermobility, it's not like our only tool is loosening or more shear strain or something like that. There's many ways that we can leverage someone's experience besides tissue mobility.
Yeah. Every therapy has contextual or what we call non-specific effects, right?
Yeah.
The interaction with the person, how being in the presence of somebody who cares, who has a physical presence and sort of a support, and especially somebody who puts their hands on you, right? And then there's a lot of communication that can happen non-verbally through somebody's hands, but also talking and when people feel that somebody who is a good therapist is actually physically kind of contacting the area that actually hurts in a way that's supportive and caring and intentional, that's very powerful, psychologically. So there's a lot of contextual effects, and these effects are part of the treatment. They're very important.
So are those real or are they imaginary?
Oh,
I'm sorry. I get that. I'm sorry to ask that question.
There's nothing imaginary about what I just described, right? This is all real. This is happening. Yeah. Whether it's happening in the person's, nervous system, there's some incredible studies right now that are being conducted with they're mainly in the acupuncture world. It's fascinating. A patient and a practitioner that are being functional MRI scanning simultaneously. It's called hyperscanning. It's unbelievable. So what they do is they do sort of simulated treatment where the practitioner, I don't begin to understand the intricacies of these experiments, but basically this is just to show that there's the therapeutic alliance between a patient and a practitioner is reflected in both of their brains at the same time. Mm. So there's this amazing communication that occurs between in the nervous system during a treatment between the patient and the practitioner, and that's real. That's measurable. Thank you. Yeah, it's real.
Right. I mean, in some ways, no surprise. Something's happening both there's brains. It's in other ways, so great that it's measurable and observable, and that someone like yourself can be a spokesman both for the mechanical effects on the tissue level, but also saying this is happening within a context. And let's not leave that out too. What do you think, Whitney?
Yeah, it does seem like there is a continuum there of those things. I remember seeing some other things written about acupuncture, about looking at effectiveness and saying that there were sometimes, cultural factors and things like that that made it more effective with certain patient populations than others. And a lot of that had to do with belief in the treatment and things like that. And it is fascinating to see that intersection between what are potentially some of the more grounded physiological effects and some of those other context effects that may also be interacting with the systems as well.
And they're all very real. When we
Yeah.
talk about what placebo effects are, I like to think of placebo effects as healing responses, self-healing responses that a person can activate in response to being in certain circumstances. And, you can do a fake, treatment, but there's still a treatment happening. There's still something that the person interprets as being some kind of trigger to help them to activate some healing responses that can happen even with placebos.
Yeah.
So, yeah.
I'm glad you mentioned placebos, because there's so much complication around that hypothetical question I ask you, is that real? And you've just made a really great case for how it's real, not only real, but it's part and parcel of what we offer.
It's important. It's important that we understand what it is. Yeah.
Nice.
Yeah.
And there's some excellent placebo research happening right now all over the world. This is an area of research that really needs more attention. It's very important.
These are certainly fascinating topics, and I know we could go on for days digging into some of these things, but tell us a little bit, what will you be talking about at the Fascia Research Congress?
I'll be talking about fascia. I'll probably, I don't have my entire talk mapped out at the moment, but one of the things I will very likely talk about is some of the new initiatives that NCCIH is leading. One is, I already mentioned, myofascial pain, developing technology to measure and especially imaging technologies to better understand myofascial tissues. We think this is absolutely crucially important. Another important initiative is something called Rejoin, and what that means is that, imagine a joint, right? Imagine somebody has pain in their knee. And their knee hurts. Well, you assume, right, that this person is saying, well, I have pain in my knee. It must be arthritis. It must be because my cartilage is kind of rubbing. People talk about bone on bone, that kind of thing. That's why you have pain. But there's a lot of things in the knee and around the knee besides cartilage. There's a joint capsule, there are ligaments, there's fascia, there's muscles. How do you know if you have pain in your knee where your pain is coming from? You don't. And we know a lot less about what we call the periarticular structures around the knee than the articular structures, the cartilage, the synovium, the bone, because we've been looking. We have ways to image those structures, but we don't yet have very good ways to image what we call the soft tissues. Yeah. So we think that by improving our ability to understand myofascial pain, this is also going to improve our ability to understand joint pain, because we think that myofascial pain could be a big component of joint pain. Yeah. And that problem with myofascial tissues may actually lead to joint pain. Because if your myofascial tissues are not healthy, if you have reduced mobility, if you have imbalance in your muscles, your joint may become misaligned. The mechanical forces on the joint are going to not be correct, and you're going to get wear in your articular surfaces. So by addressing the myofascial tissues, the periarticular tissues early, you might be able to prevent joint pain. So we think this is a really important area. I'm going to be talking about that.
Wonderful. Thank you so much for that. So, with our audience being predominantly those doing soft tissue manipulation of various one form or another, is there anything else you'd like to leave to this audience to tell us before we wrap up today, like last words of wisdom for those people doing this type of work?
Well, a lot of what I talked about is about putting things together. I talked about connective tissue, connecting the whole body. I talked about, understanding the relationship between the musculoskeletal system and the immune system, right? Inflammatory responses occurring within connective tissues. And also talk about the importance of what we call whole person health, which means paying attention to all of the different factors that kind of contribute to somebody being more versus less healthy. Nutrition, physical activity, and also psychological factors like stress, sleep. All of these factors are important, and they're important no matter what part of the body you look at. So at NCCIH, our new strategic plan is really focused on this, on whole person health, and really understanding the factors that influence whether somebody is going to move towards disease or back towards health, because we think this is an important piece. We're really focused a lot more on what we call pathogenesis, which is the creation of disease, as opposed to salutogenesis, which is the creation of health. We need to understand much better how to promote that, how to encourage healing of tissues and resilience and health restoration. So these are the components of whole person health, are what the whole person, meaning the whole, and health, which is moving towards the health direction.
Wonderful. Thank you so much. That's wonderful, inspirational ideas for, I think, a lot of the people who are doing this type of work.
And where would you send our listeners if they wanted to know more about your work?
Well, the first thing I would suggest is that people visit our website at nccih.org. It's .nih, right?
nccih.nih.org.
.gov, excuse me. What am I talking about? .gov. And that to check out a lot of the presentations that I talked about are on my director's page. We also have links to video casts of all of the workshops that I mentioned that are all listed on our website. We also have a lot of information on various different kinds of therapies. We have a lot of our science pages. I have many different information for practitioners, for consumers, for researchers. So it's a really good resource. And follow us on social media, Twitter, etc. So.
Well, that certainly sounds wonderful. And thank you again so much for your time today, Dr. Langevin. We know you're very busy, and we really appreciate you taking the time out to speak with us and our listeners. So keep in mind, the Thinking Practitioner Podcast is supported by ABMP, the Associated Bodywork and Massage Professionals. ABMP membership gives professional practitioners like you a package including individual liability insurance, free continuing education and quick reference apps, legislative advocacy, and much more.
ABMP's CE courses, podcast, and Massage and Bodywork magazine always feature expert voices and new perspectives in the profession, including me, Til, and Whitney Lowe. We're both there. Thinking Practitioner listeners can save on joining ABMP at abmp.com/thinking.
And we would like to say thank you to all of our sponsors and to you, the listeners. We thank you for hanging out with us here today. Be sure to check out the Fascia Research Congress on their website there. You can stop by our sites for show notes where you can learn more about connecting with the Fascia Research Congress. So over there, show notes, transcripts, and any other extras. You can find that from my site at academyofclinicalmassage.com. And Til, from your site, where can people find that?
advanced-trainings.com. If there are questions or things you want to hear us talk about, email us at info@thethinkingpractitioner.com or look for us on social media just under our names. Mine remains Til Luca. Whitney?
And mine still today is Whitney Lowe. You can rate us on Apple Podcasts as it helps other people find the show. And you can hear us on Spotify, Stitcher, Google Podcasts, or wherever else you happen to listen. And please do share the word and tell a friend. It does help us get the word out to get other people exposed to it. So thank you again, everybody. Thank you so much again, Dr. Langevin, for spending some time with us here today. This was a wonderful, inspiring talk with everybody.
Pleasure.